I get to talk to you guys about ED agitation. I got home at 2 last night. It was completely wild last night where I work. And last night, there are themes every night. You know, the night before last, it was gunshot victims everywhere. They were all over the place, hanging off the ceiling. Last night was the missing vertebral body night. We had a Pott's disease. We had a metastatic disease to T3 that was gone. We had a discitis, missing T2, T3. We had 3 people missing vertebrae last night in their workups. All came in with back pain. All had good red flags for back pain. So be aware of the back pain patient. We had 3 of them that had horrendous problems last night causing their back pain. All 3 were first presentations as well. One had thoracic back pain. Beware thoracic back pain. Midline thoracic back pain is never good. Never good. One had a history of some weight loss, big warning sign there. No history of cancer, but weight loss out of proportion. And one was an immigrant who had some weight loss and some night sweats. So we had all the red flags. All were back pain as their chief complaint. All 3 had a reason to get worked up, and all 3 had horrendous, nasty business. It was MR night. I don't get MRs where I work, hardly at all. You have to offer your firstborn child, your car, everything, wash the radiologist's car to get it done. We got MRs all night last night, so it was an interesting evening. We also had agitated patients. One of the things about county hospitals, like most hospitals in general, but county hospitals in particular, somehow we end up centers of excellence for incredibly dysfunctional systems and agitated patients. Agitation is something we all take care of a ton in the emergency department, ranging anything from the truly crazy person, or the person with an overdose of some sort, or recreational drug of some sort, or the person who's a little bit demented at baseline and now is agitated and you're having trouble getting them sedated enough or calmed down enough to take care of. This chapter focuses on 2 major categories. One is what do you do with the agitated patient. We'll talk about sort of approaches. And the other is what causes ED agitation that isn't just our usual, psych stuff. It's just some crazy person. And the beginning of this chapter does mention, be careful with the agitated patient, especially an agitated patient that isn't usually agitated, that doesn't have something underlying. Great example of this recently. We had a mid-40s-year-old woman who came in with crazy. She was psychotic, she was seeing things, she was violent, she was suicidal, she was homicidal, and she went to our psych ER and sat there for 3 days until she finally wasn't getting better with anything that they did. They got a little worried, she was tachycardic, etc. We finally got her over to the medical side, and she had raging lupus cerebritis and is still not doing well. From newly diagnosed, out of the blue, lupus cerebritis, raging lupus cerebritis. So the agitated patients are difficult for us, and especially if they carry any pre-existing diagnosis of something psychiatric, we make assumptions that sometimes are wrong. So I think agitated patients are something that we should use as our own red flag trigger. It's like, they're difficult, you tend to gloss over things, you tend to not do as thorough of evaluations as you might otherwise because it's hard. It's something you should almost make yourself go do. And we'll talk about how to calm them down, but remember the differential is pretty huge. And we think toxic and psych primarily, but things like CNS infections can absolutely cause this. Bleeds can cause this. There are other things, and things like collagen vascular disease can cause this. So be aware of other things that can cause agitation. And we all know that somebody who's baseline a little bit off, so somebody who has mild dementia, can end up really agitated from something as simple as a UTI. So the differential is quite broad in an agitated patient. So part of our job is to keep that differential broad and remember the things that can cause it and do appropriate workups. If you need a tox screen, send it. It's one of the few times it might be helpful to you, because if it's negative and you have other things to worry about, like, was this cerebritis? This woman's whole workup had been negative in the psych ER, and she was still completely whacked for no apparent reason. So if things aren't fitting, you're going to have to do sort of a more extensive workup, including perhaps things like CTs and LPs. But that's sort of the general gist. Let's get into how do you calm an agitated patient. And the whole first half of this talk talks about that. One thing I think that everyone should have is what we have in our ER, which is a drunk whisperer. We have a nurse who is unbelievable. She works a lot of PMs. Thank God I work a lot of PMs. And she is unbelievably good at taking crazy people and calming them down. And she gets very quiet, and she gets very close, and she makes them look at her, and they go from the two centers of the human brain that are the last to go are the protect your privates center, right? Grab your privates, and the swearing center. Right? She is, it really truly, before you die, everybody says F-bombs, grabbing their privates, and then they die. I'm not sure what the deal is, especially in trauma patients. And she is really good at getting the F-bombs to go away and getting them to calm down. So if you can have a drunk whisperer, that is fantastic. Often we don't have a drunk whisperer or a crazy person whisperer. She's amazing. I wish I could clone her. We have to use drugs, and we often do default to drugs appropriately. Chemical restraint is fine to do, and often appropriate not just for the patient safety and the staff safety, but also to get an urgent workup in somebody who might be sick. And you have no defense of letting somebody stay wacko for a while if they have potential to be sick and you're not addressing that. So the first couple of abstracts look at what to do with that sort of nursing home patient or that demented patient who's now agitated and too kind of agitated to get the workup that you need, like the CT or blood tests or et cetera. And if it's an older person, a couple things to remember, they're pretty fragile. And the dictum of start low, go slow is very, very applicable to older people with everything. Okay, if you're taking care of blood pressure, if you're taking care of pain meds, if you're taking care of agitation, starting low and going slow. And it turns out that even low oral doses of haloperidol work great. Milligram, 2 milligrams, oral dose, if you have time to just let them kind of chill, they work fine, absolutely fine. And the lower doses have much less risk of the side effects you might see. So low doses of Haldol work great in older people, and just kind of keep that in mind that you just can give it orally, milligram or 2, it's plenty. And Haldol overall is a great first agent for agitation. It just is. It's cheap. It has bazillion years of experience out there. And we know the side effects that it has. We know how to address those, which we'll talk about in a second. And first line for Haldol, there's an oldie but goodie paper. It's a 1978 paper in here, number 2, which, by the way, tells you how old the abstracts are. The abstracts are an amazing database out there that goes back to the 1970s on papers you can search if you want to. It's pretty cool. That's a 1978 paper that says Haldol works and it's great. And the reality is it is. In the 1970s, another drug came out that was absolutely fabulous, which was droperidol. How many of you use droperidol now? Hands high. Oh, God bless you. How many of you didn't and went back? Okay, how did you do that? So you just went back and... So it was off your formulary, back on formulary. How about you? Same. So it was off and now back on. Ours is still off. I can't even use it. Yep. Right. So droperidol, which has been around since 1970, so we have 43 years of experience with droperidol. Droperidol and it's been used over 10 million times, 10 million doses, mainly, to be perfectly honest, in the OR. They use it all the time in operations. In fact, they were mourning probably more than we were when it got pulled. What happened in 2001 is it got black boxed. And it got black boxed in a way that if Jerry were here, he would paint the whole conspiracy theory, which, to be perfectly honest with you, was completely legit. What happened with droperidol is the company that basically bought it also produced one of these newer generation sedative agents. And when they bought it, they torpedoed it by taking cases of prolonged QT syndrome with usually one death. And that death was actually somebody who was also using cocaine, might have had something to do with that. But basically, they reported themselves multiple times. And it's kind of a sad story, and it's truly conspiracy theory stuff. But they ended up getting droperidol black boxed, which shunted everybody over to the other part of their company, which was one of the newer, more expensive drugs that was out there that now a lot of us use. The problem with that is that it took a drug that is really good at a lot of things. It's great for nausea. It's great for agitation. It's fantastic for migraines. It has some side effects. Okay, it absolutely has some side effects, the most common of which, or the most problematic of which, is akathisia, which I gotta tell you, if I could take that moiety and distill it down and purify it and turn it into a drug like dischargemia or something, where you say, time to go, got out of here. So it does make people get akaesthetic. There's no question about that. But it is a really wonderful drug. I will tell you now, the anesthesiologist went to the FDA and said, please, 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 would you reconsider this? Now that we know how this got black boxed and we know sort of the backstory, can you please relook at this black box, especially at the doses that we use regularly, which is little doses, 1.25. We hardly ever use these massive doses that were a problem. And the FDA said, look, the initial approval was at 2.5 milligrams or higher. We will not go back and readdress this at a lower dose. Don't come back to us. We will not do this. So we will never get the blessing to use droperidol in the doses that we use. That black box will always be there. And to be honest, those of you who've gone back to use it, I think you're perfectly fine to do so. The safest thing to do is check the QT first if you can. If you can't, that's fine. And the other fallacy of this is Haldol does it too. This prolonged QT thing, Haldol does it just as much. So, and that's not, well, it actually has its little warning now too, but it's not officially black box the same way. So honestly, droperidol is fine. It is fine. Well, our system, now we don't have access to it at all. In our system, what they did for a while, which was so ridiculous, you had to get an EKG and fax it to the pharmacist. Is that hilarious? It's like, really? Really? What's the pharmacist going to do with that except look at the QTC box and see what that number was? And it was crazy, crazy. So there's a bunch of information here on droperidol. It works. It works great. And it probably works even a little better than Haldol does overall. It's great for migraines. It just works for a lot of stuff. I think it's fine to go back and use droperidol if you have access to it. And just be a little careful with prolonged QT, people with heart blocks in general, people that have cardiac histories. Be a little careful with those, but overall, have at it. Have at it. Now, if you do use something like Haldol, should you use it in a combination? And I'm going to come back to that in a minute because there's a really good study that does that. And before I get into that, I want to ask you, how many of you have transitioned away from Haldol or droperidol to one of the newer things? Zyprexa, Geodon, those things. Okay, you're cool with that. It's actually fine to do. I'll tell you, and there's some papers in here that look at this. My favorite, and I'll tell you what you get. You get efficacy. Okay, they're great, they work. They work for what we need. They take care of ED agitation. They absolutely do. They don't do as much of the akathisia, EPS stuff, extrapyramidal symptom stuff, as the first generations do, the Haldol does. The problem that you have with that, though, is they're more likely to cause hypotension. So you have a new potential problem, and that's where, particularly in older people, you may have an issue if their volume down or somebody's really agitated and they may be dehydrated, that you have a potential for hypotension with those drugs, but that's cool. That's fine. The other thing is they're much more expensive, a lot more expensive, anywhere between 3 and 10 times as much depending where you work on how they charge for that sort of thing. So they are more expensive, but they're absolutely fine to use. My favorite paper, though, that looks at them is abstract number 9. Which basically takes 3 of these sort of newer agents, and the title of the paper says it all. You know, why drug A beats drug B, why drug B beats drug C, why drug C beats drug A. And what the point is of this paper is that a lot of the papers out there that tell us these drugs are good basically compare these drugs to each other or sham doses of a usual agent, which is just something to be aware of. Be a little bit careful of getting sucked into, oh, this is the best new thing. Be careful how the studies are published, but it's fine. I think it's absolutely fine to use either of these agents. And one of the arguments made for using the newer agents is you don't get the same amount of EP stuff, sort of the extrapyramidal symptoms. And abstract number 12 addresses this. Abstract number 12 is a really good paper. Abstract number 12 is basically looking at that concept of extrapyramidal symptoms that we see in people that get Haldol. Droperidol too, but Haldol's the one they looked at this. And they said, okay, fine. Let's look at that. Let's truly head-to-head look at dystonia in people that get Haldol and people that get one of the newer agents. And let's first look at that. So they first looked at that, 18 papers, over 2,000 patients. And they said with Haldol alone, about 1 in 10 people got extrapyramidal symptoms. And with one of the newer agents, if you use that, it was down to about 1%. That's a big difference. Okay, that's a big difference. That's great. What they did in this paper that's really good is they said, wait a second, what do we usually do for extrapyramidal symptoms? Well, we usually give an anticholinergic. So what let's do now is let's take Haldol plus a cheap anticholinergic, Benadryl, you know, one of these Cogentin, some anticholinergic, and now let's compare that combo to this more expensive new drug. And it turns out the combo is as good, if not better, than the new drug. So if you are of this old school, which we do all the time, of giving Haldol plus something like Benadryl or Cogentin, good on you. And it is as efficacious and decreases the extrapyramidal symptoms down to the same level as the new drugs. So you have a lot of options in decreasing somebody's agitation. One of the little asterisks in there is a lot of us that work in county hospitals have gotten in the habit of giving not just Haldol and Benadryl or Haldol and Cogentin, but we throw in there for good measure a benzodiazepine. And the combos were sort of the 5-2-1 or the 10-25. And you can put it in one syringe, give it in one shot. Everybody holds the patient down. You grab a thigh or a shoulder and you give them a shot, kind of blow dart them down. The problem with that is the benzodiazepine component has potential respiratory depressant properties that may be an issue. So I think if you really want to be a nuanced practitioner, what you do is if you think you have somebody who has either cocaine on board or alcohol withdrawal, particularly alcohol withdrawal, and if they're agitated with alcohol withdrawal, they probably have DTs, which is a big deal. That's a whole different issue. That's a big problem. In those two instances, the triple drug concept is great. Okay, it is great because the benzo's treating the problem. If it's just because it's an agitated older person or it's somebody you think has meningitis that you can't keep still long enough to get them worked up, I wouldn't add it. You don't need that benzo part of it, and you do have the respiratory depression. So to be a little bit nuanced, I think that subtlety is probably valuable rather than just knee-jerking everybody with the triple drug shot. So lots of ways to sedate people, lots and lots of things that we can do to sedate people, all of which work. Get yourself a drunk whisperer if you can, because sometimes you don't need it at all, but often we'll use this stuff. And it's much better than physical restraint. It works much better than, across the board, works better than physical restraint. Physical restraint has all kinds of issues, including things like rhabdo. People in physical restraints can put themselves into rhabdo if they're agitated enough. They'll just get muscle breakdown from straining at those restraints. So physical restraints is something to sort of avoid if you can. So any questions about the drugs and things? Comments, concerns, issues, things you want to share? Because the second half of this talk is really fun, which is what causes agitation. What are the weirdo things that you should kind of put on your radar screen to be aware of? And it goes through basically this laundry list of things that we're just going to touch on. And what I want you to walk out of here with is 2 or 3 things you're going to do differently next time you see an agitated patient in your workup. Okay, and I promise you'll at least have one. All right, so the list of things that can cause people to be agitated, we think of it in, I think of it in 4 categories. So 4 big overarching categories: toxic, metabolic, infectious, environmental. We forget the 4th one. Okay, we think toxic all the time. Okay, and toxic, metabolic, as far as true medical causes, not psych causes, but toxic, metabolic, infectious, and environmental. We're going to talk a lot about toxic. Metabolic, remember thyroid. Okay, please remember hyperthyroidism. Every once in a while, you're going to get the true, honest-to-God thyroid storm patient, the real deal. Infectious, we all think about. Okay, that's something we all consider. Could this be encephalitis? Could this be meningoencephalitis? We think about that. What we forget is environmental. Heat stroke is the real deal. They come in agitated, they come in altered, they can come in comatose. It's the real deal. And if you don't pick up on it early, they die. They die. So you have to be a little careful with that. And so add environmental to your list, particularly of the agitated hyperpyrexic adult. So if you have an adult with a temperature over 105, who's first of all, if it's over 100, adults don't do that, right? They just don't. Babies do. Okay, they get some of these viruses and it gets them really high fevers and they're fine. Adults don't do that. If you see an adult with a temperature of 105, 106, 107, and they are agitated, it's toxic, metabolic, infectious, or environmental. Ask the paramedics what their double-wide trailer was like, or their apartment was like. Was it aerated? Is it hot in there? Because you're going to see them in the ER. You may never know that they were sitting in a 120-degree trailer. So ask about that, because the key is to this. And if you see a hyperpyrexic agitated patient, hyperpyrexic altered patient, your resuscitation and workup should go from ABC to CABC. Cool them. Get them cool. While you're doing your workup, while you're getting your Haldol blow dart out, whatever, get them cool. And the quickest way to do that is strip them down and moisten them. Get a fan to blow over them. Evaporative cooling works beautifully. Or put ice over the big vessels while you're trying to figure out what's what. I'll tell you, if it's heat stroke and you don't get them cool, you fry them. You fry their endothelium, you fry their brain, you fry their liver. You fry them. So it's really important to get them cool first. So the agitated hyperpyrexic adult, toxic, metabolic, infectious, environmental, make cooling one of the first things you do while you're starting to do your workup. Because that'll get you a huge amount of therapy while you're figuring out what's wrong. Now, as far as the actual toxic kind of things that can go on, we're going to start with some of the things that kind of should be on your radar. One is neuroleptic malignant syndrome, and that's the first abstract in this section. It's abstract number 13. NMS is what all of our psychiatrists really, really worry about, appropriately so. We think of neuroleptic malignant syndrome associated with things like Haldol, so the first generation of the antipsychotic medicines, the phenothiazines in particular. It turns out all of your sedating agents can do it. If you're one of these second generation people, you're cool, you're cutting edge, good for you, but you still can get NMS with those. And a lot of the trigger of, sometimes the trigger of NMS is adding a drug to somebody who's already stable on one of these agents. For instance, compazine, Reglan. These are drugs we give routinely for people who may be nauseated. It affects your neurotransmitter balance in your brain and can give you neuroleptic malignant syndrome. It is manifested by a relatively slow onset, hours to a day or two, of altered mental status, often fluctuating, autonomic instability, tachycardia, bradycardia, hypertension, hypotension, diaphoresis, and lead pipe rigidity. So one of the things to go back with when you go back to work is when you have somebody who's altered, you're worried about the toxic, metabolic, infectious, environmental stuff, check them for lead pipe rigidity. If they have that and they're on particularly one of these agents, but there's a long list of agents that can cause neuroleptic malignant syndrome, you're going to go ahead and work them up for NMS, and you're going to treat them for it. The workup includes getting a CK, which is not something we usually do. So it's one of the things you're going to add to your list of labs that you're going to send in those patients. And then the treatment is basically to support them, whatever they need autonomically, cool them if they need to be cool. They're often hyperpyrexic. And then dantrolene and bromocriptine are on your list for neuroleptic malignant syndrome. The other thing to know about NMS is it can happen at any point in time in somebody who's on it chronically, and it can happen after the first dose. The worst case of NMS I've seen in my career was an agitated guy who had turned out to have subarachnoid hemorrhage causing his agitation, needed to get sedated, got a single 5 milligram dose of Haldol, went down and got a CT scan, raging bleed, came back up in raging NMS, and died. I'm not sure if he died from his bleed or from his NMS, but I think it was his NMS. It was a cardiovascular death. He had cardiovascular collapse, so I think it was the NMS that did it. That should not make you hesitate to use the drug if it's appropriate to use. And the other weird thing about NMS is that having it once doesn't mean you're going to get it again if you go back on the drug. A lot of these patients have only certain drugs that they can be treated with. They're bad schizophrenics, et cetera. It's hard to treat them. It doesn't predict that you're going to get it again. So on our radar, agitated on these kinds of agents, especially if they're diaphoretic, it came on kind of slowly over a day or two, and they have lead pipe rigidity, stick that on your list. Now that's in counter-distinction to serotonin syndrome, which is abstracts 15 through 17. This got on the radar screen when everybody on the planet was put on an SSRI. And there's certain things that will alter your serotonin dopamine balance in your brain and give you a risk of serotonin syndrome. And the thing about serotonin syndrome is it looks very much like NMS. They're agitated, they're febrile, they have diaphoresis, they have autonomic instability. But what they have that's different from NMS is it is rapid in onset, so whatever the trigger is, it happens pretty quickly, and they have clonus or myoclonic jerking. Okay, the reflexes are increased. So now you're again at the extremities of that agitated person, and you're checking now for clonus. So add clonus to the things that you check for, and check those reflexes. That's going to be a clue to you. Now the treatment for serotonin syndrome is supportive. Okay, you're going to do supportive therapy. So if they're super hot, you're going to make them cooler. You're going to, it's all supportive. But that will help you differentiate what might be going on with the patient. So your clues there are rapid onset and either increased reflexes or myoclonus. Yeah. Usually the CK is normal with serotonin syndrome. That depends, though, on the amount of agitation and the amount of restraint that they're getting. If you're holding down somebody who's agitated, they may bump it. So really, that is not as much of a dictum. But the CK levels are part of the definition of neuroleptic malignant syndrome. And both of these syndromes, by the way, have classification criteria that you can go Google it. Just look it up. One's Hunter's criteria, the other one's Sternbach's criteria. But it's this plus this plus this equals the syndrome. 3 of 5, that kind of thing. So that's serotonin syndrome. Anticholinergic syndrome. This you can tell very distinctly different from the previous two. The previous two can have diaphoresis, their blood pressure's all over the place, they're agitated. Anticholinergic syndrome is, you have to pay attention to your toxidrome, but it is crystal clear when you see it. We saw probably, I don't even know, probably half a dozen cases of anticholinergic syndrome this year, because everybody got their flu shot and everybody got the flu, right? The flu shot missed this year. We had a lot of people, I don't know about you, but we had a ton of people coming in sick with prolonged virally jazz, often the flu. It led to a lot of home remedies. And if you Google, home cold remedies, one of the things that's gonna pop up is making yourself a tea. And you make yourself trumpet flower tea. Trumpet flowers are gorgeous. It's the Datura species of plant. They have these flowers that hang down. They're huge, yellow, smell wonderful, gorgeous flowers. And you can make a tea out of it's supposed to be 1 square centimeter of the Datura flower in a quart of boiling water. You make a tea and you drink 1 8-ounce cup. And it's anticholinergic. So it's just like buying Benadryl over the counter. You're just drinking it. It's cool. Makes your nose all dry up. It's anticholinergic. The problem is that the patient that we saw had decided to take an entire trumpet flower, put it in a big pot of water, and drink an entire huge cup of incredibly concentrated anticholinergic Datura flower tea. And she came in red as a beet, mad as a hatter, dry as a blah blah, the whole thing. So she was blind as a bat because you get pupil dilation, anticholinergic. Okay, you get pupil dilation. Dry as a bone, you can no longer sweat. You shut off your ability to sweat by having anticholinergic toxicity. Red as a beet, you get flushed. Okay, you get flushed from head to toe. Mad as a hatter because the central nervous system effects of anticholinergic toxicity are to make you crazy. Okay, they make you nuts. And hot as a hare, you can't sweat, and because you're agitated, you're generating heat. So they'll come in 104. She was 107 degrees. She was completely dry from head to toe, whacked out totally, no bowel sounds, right? Anticholinergic, no bowel sounds, huge pupils. She was so classic anticholinergic toxicity, it was remarkable. You can fix that, and you can fix that with physostigmine. Those of us who have been around a long time, there was this era of, ooh, physostigmine, don't give it, you can hurt somebody. No. Get them on a monitor, watch all their intervals. They're usually tachycardic with this. They're anticholinergic. They're usually tachycardic. And if they are crazy, if they're nuts, you give physostigmine. It's a little dose. It's 2 milligrams, easy. You give physostigmine. They'll be mentally normal in minutes. It's like a miracle. It's unbelievable. Their agitation goes away. They wake up. It's like, wow, what's going on? It's like, whew, amazing. Anticholinergic toxicity, you will see. You'll see it with overdoses of Benadryl. You'll see it with things like the herbals. And the herbals are one of the biggest sort of problems right now with anticholinergic toxicity. People just don't know that it can, it's natural. It must be okay. Not so much. You can do yourself some harm. So anybody guys seen cases like that? We had a bunch of them this year. It was kind of just amazing. Amazing stuff. Now, another thing that can cause agitation, and you're in the land of Muscle Beach, you're in the land of Gold's Gym, is GHB. Gamma hydroxybutyric acid is a sedative. It's kind of a calming agent, and it was used by kids, and then they kind of didn't like it because it puts you into a coma, and how fun is that? But it turns out that it's used a lot by bodybuilders. A lot by bodybuilders. And just when you guys, if you decide to take a stroll down Venice Beach, take a peek. There's an outdoor gym where these big behemoths go out and work out, and you can watch them do all this, muscle building stuff. Those are the people using GHB. They use it because it kind of calms them down. They feel like it's good for muscle building. They drink these creatine sort of drinks, and they get muscle building. The problem is that they will ramp up their dose over time. Because what happens is as they take it, then it wears off, they get a little agitated, a little shaky, a little tremulous. So they'll take a little more, and a little more. And if they stop, they get a withdrawal syndrome that looks for all the world like alcohol withdrawal. They get agitated, they get diaphoretic, they get shaky, they get nausea and vomiting. It's very similar. So GHB withdrawal can come in with agitation. So if you see somebody who comes in who is cut, there is not an ounce of body fat. Their shoulders are attached to their ears because their trapezius are like, argh. That person, if they're agitated, just take a guess that there might be some GHB withdrawal going on, because that can definitely occur. And that's treated with sedatives. Okay, that's a benzo. That is truly, you can treat that with benzos. Benzos will treat that just like it will alcohol withdrawal. The other big drug right now that we're seeing, particularly in kids, well, there's two actually, is ecstasy. Let me tell you a story we had of a case just recently, and this is not HIPAA violation because it never made the news, so nobody will figure out who this kid is, but we had a teenager who was found hanging by his baby brother from a tree in the backyard. They brought him in. He was actually, and en route, the call was, it's taking 4 paramedics in the back to hold this kid down. We're on our way. He's diaphoretic, he's tachycardic to 220, we're on our way. Hanging doesn't do that to you. right? If you have an anoxic brain injury, you are not agitated and tachycardic to 220. Something was weird. He arrived completely flushed, diaphoretic like crazy, huge pupils bilaterally, heart rate to 220, blood pressure 180 over 110, in a 16-year-old kid with ligature marks here and an erection. I'll tell you what kids are doing these days. They're doing either Viagra and Cialis and ecstasy and autoeroticism. And what it is basically a wild weekend. They're often doing it associated with things like rave parties, and they're doing ecstasy. So he basically had ecstasy on board. He had all of the signs of ecstasy, and the erection went with the Cialis that they take as part of the combo. It's what kids are doing. It's just party weekend time. It's what they're doing. So they end up agitated, tachycardic, diaphoretic, confused. But the one thing that'll be a clue to you of a kid that's using ecstasy on a regular basis is look for the following. Look on their body for tattoos, they often have them, and look for one of a pacifier. Or look for a charm or an earring of a pacifier. Because what ecstasy gives you is bruxism. You grind your teeth. And if you see somebody who's agitated, who's grinding their teeth, it's probably ecstasy, okay, that's causing that trouble. There's a new drug on board out there that's also causes bruxism, but that's a clue to you. I will also tell a personal story. I went to a Lady Gaga concert, and I got to go backstage. It was kind of cool, kind of fun. I went with some of the residents. It's a great way to get yourself in with the residents, is to go to a Lady Gaga concert. But they had candy everywhere backstage. Everywhere, including all kinds of those ring lollipops that were pacifiers, everywhere. I'll tell you, there's a lot of ecstasy going on at Lady Gaga concerts. It's all over the place. It's kind of remarkable. I did not. On tape, I did not. So the other thing to know about ecstasy is they get very thirsty, especially when they go to rave parties. They will drink a lot of free water, and they come in hyponatremic. So another clue to you that ecstasy is causing that agitated kid is their sodium comes back at 120. It's like, why would a kid have a sodium of 120? That's another clue to you that ecstasy is what's on board. And all of this is supportive care for these folks. Now, bath salts is the latest. You guys seeing bath salts? Oh my God, unbelievable. It's unbelievable. You're getting these 12-year-olds, 15-year-olds, crazy coming in whacked. Absolutely crazy, 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 crazy. They come in hypertensive, tachycardic, hallucinating, incredibly agitated, and they are hyperreflexic. They often have myoclonus and they have bruxism. So do that exam. Look for the hyperreflexia. Look for the clonus. Check that stuff out, because and again, supportive care for this stuff. You often end up needing to put these kids down. They end up really, really agitated. It's really scary. Cocaine's kind of passé. Oh, it's just cocaine. We're kind of bored with cocaine these days. That's kind of passé. And the last thing I'm going to mention is abstract number 28, which is alcohol withdrawal. The real deal alcohol withdrawal, the true DTs, is life-threatening. And it is not just, I see a pink elephant, and I'm a little shaky, and I'm a little tachycardic. It is basically metabolic anarchy. You are very hypertensive, you are very tachycardic, you are very diaphoretic, you are throwing up, you're combative, you are sweaty like crazy, and it takes a boatload of benzos to treat that person, often to the point of so many benzos that you need to intubate them. Okay, what you need to do is get them calm, no matter how much it takes, get them down. There's some evidence propofol might work, but honestly, I think benzos are really the accepted standard of care for true DTs. And this is not the, I've got a little bit of shakes. This is the whacked out person. And just know that once they hit DTs, they end up with a 3 to 14 day course before they're better. It just is. So they are an ICU admit. It just is what it is. It's basically, until all those neurotransmitters get back to normal in their brain, they are out for 3 to 14 days. It's usually about 3 to 7. So really sick, and please feel comfortable. And by the way, anybody with mild alcohol withdrawal, please treat them. Give them, even if it's an oral benzo, you'll prevent later DTs. DTs is also later. It's 3 days after they stop or decrease their drinking. It's not today. Okay, I stopped 6 hours ago. That's early alcohol withdrawal. This is, boy, I had a little bit of shakes. I even seized a couple days ago, and now, crazy, 5 days later, that's DTs. All right, so now you guys know how to sedate people. You know a little bit of this and that about the things that can cause agitation. Any questions?